We shall now go on to our next speaker, Dr. REVATHI, who is the Chief of Cornea Refractive Surgical Services at Aravind Eye Care Systems, Coimbatore. Again, a very versatile, dynamic surgeon. And she is going to tell us about MSICS in pre-existing corneal opacity. So on to you, Dr. REVATHI.
Thank you, Dr. Chitra. I hope I am visible, my slides.
Yes.
Yeah, thank you very much again for giving me this opportunity of taking part in this wonderful teaching platform, the AIOS series. And of course, I may be a little odd here. I'm going to talk more about the corneal pathologies and of course, doing a cataract surgery in the presence of a corneal pathology. So the corneal pathology, especially, and I can take it as an ocular surface problem. And this can intervene in preoperative planning, intraoperative visibility, postoperative healing also, and also sometimes the disease can get reactivated after the surgery. So in the preoperative planning, many times the question will arise when we come across with the corneal opacity or corneal pathology, which is the main reason for visual loss, and whether we are going to deal it as both together or which one to be dealt with first. And the first two the pictures of the same patient, often you can come across patients like this, many times mistaken for dystrophy because it is bilateral, but these are scars due to old eye kill. In very elderly people, you can come across. Surprisingly, for this kind of a cornea, they would have had good vision, reasonably good vision for a long time. And if you probe the history, it will be the visual deterioration is only of recent onset after the cataract. So in these cases, you can just go ahead with do only cataract. Of course, the patient will not have any big difference, but only for the surgeon, it may be a little difficult because of the poor visibility. And of course, SICS is an ideal surgery in such situation. And even in dystrophies, granular dystrophy, many patients may not even aware of it till they come for cataract surgery. We can just go ahead and do cataract. But if it is a macular, very rarely they come to the level of cataract before undergoing a keratoplasty. But in case of endothelial dystrophies, the whole thing is different. Of course, we prefer to do either both, mostly both together. And also long-standing opacities, we have to keep amblyopia in mind. And accordingly, we have to give promises to the patient during cataract surgery. And pterygium is another one which can interfere with induce astigmatism, so it can interfere with IOL power calculation. And also sometimes if it is massive and bilateral double pterygium, interfere with the entry location and compromise visibility. So again, the often asked question, what to do, whether it can be done together or at a different time. My take is always one at a time. And if it is an immature cataract, I would like to re-establish the ocular surface properly and also reduce and stabilize the induced astigmatism, and then do a proper IOL power calculation and go ahead. And if patient's preference is mainly to regain vision, and if it is a mature cataract, I would go ahead with only cataract surgery. And why I say that is because of this. Just removing the pterygium alone is an obsolete procedure. Often you will end up with the complications like this. And that too in the presence of a large wound which is entering into the globe. This is not at all a preferable logical conclusion. So naturally you would like to, you have to do a conjunctival autograft in the presence of another big ocular surface trauma in the presence of an intraocular wound. So it's better to go to stabilize the ocular surface first and then go for the pterygium surgery or the cataract surgery later if it is needed. Then the IOL power calculation can be also challenged by the irregular astigmatism caused by the corneal pathologies like scars or ectasia. Often PMD will be associated in this age group. And not only that, even the corrective surgery like keratoplasty can result in irregular astigmatism often because of the, especially PKP, because of its irregular wound healing. So then it may be quite challenging to calculate the IOL power. There are many methods, but still we have to keep in mind the refractive surprises will be there. And if the astigmatism is regular like this, maybe we can plan our incision as Dr. Ravindra and others pointed out. But still that even I too feel that even including the limbal relaxing incisions often can lead on to regression over the years, and later again the astigmatism can reoccur. And the corneal degenerations or any, especially the superficial ones like BSK or the CDK, you can go for either PTK or the superficial keratectomy to make the visibility more as well as to make the surface more smoother. If usually with the BCL, it can heal very well, but sometimes a very large and thin cornea, you may need a amniotic membrane. Allow the normal epithelial healing and then go for your plan this cataract surgery. And here the adherent glaucoma, I would like to warn, if it is in the periphery, not in the center, just go ahead with the cataract surgery alone. And most importantly, do not touch the adherent iris to the scar. And because this invariably can lead on to a large descemetorexis, descemet's membrane detachment and compromised cornea. It's better not to disturb it at all. And often you will come across with poor pupillary dilatation in these cases. So in case, if it is a soft cataract like this, you can just go ahead and, as others pointed out, you can go ahead and do the surgery. But if it is a dense cataract or a nuclear sclerotic cataract, you may need something like some kind of a technique to enlarge the pupil, as the surgeon here, Dr. Jebin, tried use the hooks to enlarge the pupil till at least the capsulorhexis, and later before removing the prolapsing the nucleus, he just removed the hooks so that they will not interfere in that step, and then go ahead with the normal surgery. Again, you can see this adherent glaucoma here. The cornea is quite thin. The scar is quite thin. You can see the iris pigment behind. So touching this to release the iris and trying to regain the anterior chamber is not at all a good idea. Just leave it in that position only. So coming to viral keratitis, if you know it is a HSV keratitis, then you have to take some precaution. The surgical stress as well as the post-op steroid is going to reactivate the condition. So go for oral antiviral prophylaxis. Start it at least 2 weeks before and continue as long as you are going to use steroid. And even if there is a scar which you are not sure HSV, but if you are in doubt, it's either better to start it or closely observe the patient. But subepithelial keratitis like this kind of opacities in a post-adenoviral, it doesn't need any prophylaxis. Often the post-op steroid is going to clear the condition also. And some of the other ocular surface problems like MGD, which often will be associated with cataract patients, you have to treat it first, because the main problem, if you don't treat it first, you may end up with a tunnel infection. So it's better to treat it properly, take it seriously, and then go ahead with the cataract surgery. And atopic periocular allergic dermatitis also is something to be warned of. These patients are often associated with the cell-mediated immunity, defective cell-mediated immunity, and they are more prone for infections, especially fungal infections. So it's better to get a dermatology clearance as well as continue their treatment and then go for cataract surgery. Coming to the dry eye, again, it's a commonly associated condition. If it is a non-immune mediated, of course, only the problem is wound healing may be problematic. Persistent epithelial defect can occur. And of course, ocular flora might be altered. So go for a conjunctival culture before surgery, and also use plenty of lubricants and temporary punctal occlusion. All those steps you can take and go ahead with the surgery. But if it is a immune mediated, you have to keep in mind it can trigger the post-operative sins and other problems. So you have to get rheumatologist clearance and also continue the immune modulation throughout your surgery and in the post-operative period. And the same thing holds good for conditions like PUK or scleritis. And even in a quiet PUK like this, because of the compromised ocular corneal structure, your entry wound will be a challenge here. Sometimes you may need to restore the integrity, and then you have to go for surgical intervention. Again, you have to continue the immunosuppression, and because they are in immunosuppression, perioperative, even systemic antibiotic coverage may be advisable. And this is another patient post-thermal injury, probably because according to the history, who landed up in our camp. And again, this is quite difficult. Only a nasal small part of cornea, 1/3 of the cornea was clear. The surgeon was sitting on the nasal side and going ahead with the surgery. We didn't have time to go for any ocular surface reconstructive procedures here. So that is somehow you may end up with like that. And other cicatricial conjunctival problems like Post-Steven-Johnson or OCP, the main thing is reduce the inflammation, restore with surgical intervention graft, and do not touch the cornea in conjunctiva in these cases. So go for a clear corneal section or take minimal injury to the conjunctiva. A non-healing epidefect sometimes you can come across in a post-operative period, and maybe due to diabetes or missed out ABMD, then you have to use plenty of lubricants and epithelium-friendly drugs. In these cases, you have to plan even before. SLK is superior limbic corrective conjunctivitis is one condition where MICS is ideal, especially the superior approach, because this itself will heal this conjunctival callosis, which is a localized one, and it will give a lot of relief to the patient also. So in conclusion, any active ocular surface or corneal problem has to be controlled, and diligent preoperative workup and planning is important, and reactivation of a chronic pathology is also to be kept in mind, and it has to be planned. A prophylactic whatever measure has to be taken in these cases. Thank you.
Wonderful presentation, Dr. Revathi. I mean, so beautifully depicted with a lot of teaching videos. Hats off to you. So I'll ask you one first question before we go on to the expert panel. When you're doing a combined triple surgery, what are the pros and cons for doing SICS against phaco in these corneal procedures?
Triple means you mean if it is a PKP, yeah, if it is a PKP, there is no question that wound itself is enough to do the cataract surgery also. But the tips are like here, the chamber is open. So the whole thing will be like reverse. It will be convex. Your rexes, your aspiration of cortex, everything should be done in a convex manner, because the bag will not be, the posterior capsular bag will not be in a concave manner. So that you have to keep in mind and proceed when doing this. And if it is EK, then of course we can do in any way, like if it is DSEC, we can use it as a SICS, or if it is a DMEC, we can go for, depends on, I decide it only on the condition of the lens and the nucleus.
Yes. Question to the expert panel. If it is a case of a microcornea and you are doing an SICS and you end up making a smaller sclerocorneal tunnel, but you have a dense cataract, what are the challenges in nuclear delivery and what would you want to tell us on that? Anybody on the expert panel? Dr. Saurabh, you would like to add anything here?
Yeah, I think those are tough cases even for SICS, because the anterior segment is much smaller than the size of the nucleus. So I think in such cases, we have to be prepared for even posterior approach sometimes, because it depends on the size of the cornea. Of course, if it is big, 8 millimeter and bigger, you can do regular SICS. Even phaco I would prefer rather than SICS in such cases, because since the nucleus is very big and anterior chamber is very small, I'm not experienced with phaco fracture. Maybe Ravindra sir can answer about that more, but I would prefer phaco. And if it is very small cornea, then I would even sometimes go for a posterior approach.
Dr. Debashish?
Yeah, I think what Saurav said, the only thing that has to be kept in mind that here we have a surprisingly very big nucleus, because so that we need to keep in mind. So the rexus has to be adequate, incisions have to be adequate, phaco fracture techniques. I prefer the snare technique, but yes, I mean, I would prefer phacoemulsification over SICS, given the small nature of the anterior segment.
Yes.
Not only that, many times they will be associated with the iris coloboma and lens coloboma like that.
Yes. So you are challenged by the zonular weakness also in some of these eyes. How would you, what is your cutoff in a microcornea for an IOL, Dr. Revathi? Or nowadays we have customized IOLs?
No, I have not much experience with the customized IOLs. generally the normal regular IOLs only. As Dr. Bhattacharya mentioned, the lens as such will be of normal size, usually in these cases. So only the anterior part will be smaller.
Yes. Yes. Any other question, Dr. Satyajit, Anaga? Shall we?
Revati ma'am, is there? Okay, go ahead, Saurabh. Go ahead, Saurabh.
Yeah, Revati ma'am, thanks a lot. So such a excellent presentation and teaching. I wanted to ask, because we commonly give topical NSAIDs post cataract surgery. With the corneal, these problems, ocular surface disorders, how do you put the post-op regimen? Because I think NSAIDs should be avoided. So how do you use steroids for longer period, or you change some other medicines that you use along with that?
Yeah, as I said, generally in these cases, I would prefer, if it is an antibiotic, I would prefer a chloramphenicol based one or a ofloxacin based one. These two are more epithelial friendly drugs. And steroids, of course, in such cases, of course, you can go for dexamethasone combination rather than prednisolone. And of course, steroids depends. It need not be always longer time, but if it is an ocular surface inflammatory condition, better to use it before and quieten the thing. And always in this case, I would prefer to do a conjunctival culture. I don't know. There are many. I mean, it is controversial whether it is really useful or not, but I'm sure these cases, the ocular normal flora will be altered. So it's better to go for a culture and then plan your surgery.
And lot of lubrication also along with.
Yes, lot of lubrication, preservative-free lubrication. Yes, of course.
Revati ma'am, I had a question. Boliye, Devasit sir, boliye.
No. I just wanted Dr. Revati's lecture was so good, so comprehensive.
Yes.
I really want to thank ma'am for the same. And
thank you, sir.
Just to highlight, that the acyclovir point that she made. I mean, she even said that even if a scar doesn't look a typical HSK scar, to be on the safer side, because the reactivation of these disease after cataract surgery is a big problem. So, I mean, start it a week before and at least continue it 2 months or till you are giving topical steroids, at least for 3 months. And so, I mean, these points are very important and less talked about.
Yes, very true.
Yes.
Yes,
I have a
your question.
Dr. Chitra, I have a small
Go
question for
on.
Dr. Revati. Dr. Revati, you said persistently that any adherent glaucoma should not be separated from the iris, should not be separated from the cornea. But if it is circumscribed, if it is just attached there, let it be vascularized glaucoma. I have a tendency to, I have urgent. I always do. I fill it up with viscoelastic so that it's in traction, and I take vanas, long blade vanas, and cut it off. And even vascularized adherent glaucomas, I've had no problem. The bleeding is not continuous; it stops in no time. But of course, you showed a case where the iris is gone into the cornea. Even in such cases, I just try to trim the iris around so that at least we have a normalized anterior chamber at the end of surgery. So what are your comments? Why did you?
Yes, sir. Sir, maybe with your experience, as I said, don't try to release it. You can cut it, and I mean, there will be a surgical coloboma there. You can cut it and leave it. That is okay, but that should be planned. I mean, for beginners, generally, I used to do that. We have the tendency, okay, we are doing a surgery, we'll try to reform the anterior chamber. So we'll try to release it. That's a wrong move. But you can cut, and that is the elegant way so that the adherent part will not be affected at all. So
I agree that you should not be
part
pulled.
only will be cut.
It should not be pulled from the cornea. I fully agree with that. But come very close to the cornea. Don't touch the decimates. You raised a very nice point that it can tear off the decimates. But if you put the attachment on stretch by deepening the chamber there, take a long blade, go very close to the cornea and trim it up. I mean, that's what I do. And even people enlarges there, and it will facilitate your cataract surgery for a paracentral opacities.
But another important question Anaga has to you, Dr. Revati, about topical cyclosporine drops. Would you consider using them long term in these corneal based procedures? Cost of it,
If
of
it-
course, is a deterrent.
Yeah, if it is an associated ocular surface problem, yes.
Yes,
Yes.
yes.
I think
Dr.
Dr.
Divya?
Sinha wanted
Yes,
to ask
Sapnit,
something.
your question.
Dr. Divya wanted to comment. You are muted,
Yes,
Dr.
sir.
Divya.
Yes, sir. So my question for Revati madam is, how do you calculate IOL powers, madam, for compromised corneas? Do you follow anything in particular? One is to look at the other eye for the
Yes,
approximate,
yeah, that is,
especially when we're doing a PK with cataracts.
Yes.
Yeah, as I said, for some time we were following the OBSCAN method, where we do the OBSCAN and see whether it is a regular astigmatism and just go ahead and do. Even you can go for even toric IOL in such cases. But otherwise, what was described by Dr. Carlos, you can go and calculate the mean power, posterior mean power, total mean power, and total optical power, and take that as a K1 and K2 and calculate and all. But the problem is the newer OBSCAN machines, they don't have that facility at all. Only the old one, OBSCAN 2, I think we can do that. I think that machine is almost obsolete now. So that method is, I don't think it is of use. But even in Pentacam, there are some ways, something similar to that has been talked in the Keracon. But I don't know about that. Somebody talked about it in Keracon, some similar method.
Okay, ma'am.
Revati ma'am, very nice presentation. Since we are talking about advanced gadgets, in these compromised corneas, especially when we are doing SICS, is there any role of specular microscopy, especially because you are bringing out the nucleus very close to the endothelium and the corneas are compromised? Is there any role of specular microscopy before doing such cases?
Yeah, but if it is some gate or something ways we can do. But if it is a scarred cornea, it's very difficult to get. But of course, post PKP or post keratoplasty cases, yes, specular we have to do. And whatever be the specular, of course, we are going to use only cohesive or preferably a combination of both.